Welcome to AETCM, the emergency medicine channel.
Yeah.
Presenting the case of 82-year-old female who came to ER with complaints of decreased response since last 3 hours. On initial 10-second assessment, the airway was patent and there was no pooling of secretion or gurgling of sounds. On breathing, the respiratory rate is 18 per minute. The saturation was 96% in room air. And the circulation, the BP was 170 by 80 millimeters of mercury and pulse rate was 100 per minute. Disability, the GCS was E3V2M5 and the pupil was reactive equal and reactive bilaterally. And exposure, the temperature was 98 degree Fahrenheit and GRBS was 21 milligram per deciliter.
Okay.
So that time we inserted a large bore cannula and we had given 100 ml of 25% dextrose. And after that, the patient's sensorium had improved to a GCS of E4V4M5. And the repeat GRBS showed 300 milligram per deciliter. And after that, she was started on IV fluid of DNS as maintenance and hourly monitoring of GRBS was done. Moving on to the sample history. 82-year-old female, a known case of type 2 diabetes mellitus and dementia, came to emergency department with decreased response since 8 p.m. at night. There's a history of feeling of generalized tiredness, decreased talk and decreased appetite since night. And there's a history of fever with cough with yellow expectoration since last 4 days. And there is no history of deviation of angle of mouth or vomiting, involuntary micturition, headache or one side weakness. Allergic history, the patient is not allergic to any medications. Medicinal history, the patient is on insulin human mixtard 18012. Past history, the patient is a known case of type 2 diabetes mellitus since 20 years and patient is also a known case of dementia and patient has history of recurrent aspiration pneumonia. On systemic examination, the chest, there was bilateral scattered crepitations was present and CVS S1, S2 was normal. And on CNS, the patient was moving all 4 limbs, the plantar bilateral flexor along with reflexed 2 plus all 4 limbs.
Okay, so what's your diagnosis right now?
So this case is a case of hypoglycemia. Most probably due to an underlying infection could be one of the cause or...
Okay, so that you can put it as a precipitating factor.
Yes.
So what could be the reason for hypoglycemia?
She has decreased food intake.
So decreased food intake and she has taken her insulin also. So that is a straightforward. The priorities when the patients come to the ED, our aim is to correct the hypoglycemia. That's the most important thing. But the problem, what we have to understand is that certain group of patients, we need to be little bit vigilant and we need to evaluate during the time of hypoglycemia. So don't wait for any investigation. That is the first thing. I am telling you this thing, but just for the theoretical per se. But somebody is coming with recurrent hypoglycemia, you need to consider this. Or you are admitting someone for evaluation of hypoglycemia, you are inducing hypoglycemia and you are treating and you are looking for something else. So we can divide hypoglycemia into 2 categories basically. Those who are having hypoglycemia in diabetes, those are not having any diabetes and going into hypoglycemia. Then otherwise we can call it as spontaneous hypoglycemia. So this will be the 2 category of patient. So priority to come in the ED, I will say it is just like any unresponsive patient. The first thing that you should be doing is checking a glucose random blood sugar. So that is the GRBS should be checked for and you have to correct the hypoglycemia. So how will you correct the hypoglycemia? What is the guidelines say? So you can have pediatric, you can have neonatal, you can have adult hypoglycemia. So this is an adult elderly lady who has come with hypoglycemia. How will you treat that hypoglycemia? So is there any specific recommendations for that?
So in this patient, we can give 25% dextrose.
See, don't always think about 25% dextrose. Whatever the dextrose solution that you have in hand,
Yes.
That should be the immediate. What is immediately available
Yes.
to you? If it is 5%, if it is 10%, if it is 25%, you give dextrose. That is the key. And most important thing, approximately 20 to 25 grams
Yes.
is what is more important. Suppose you wanted to give 5% dextrose, you have to give nearly 400 to 500 ml. If you are having 10% dextrose, you need to give how much? You need to give around 250 ml, 200 to 250 ml. So if you have 25% dextrose, it is easier, you can give 100 ml. So whatever the fluid available should be given to the patient. And next important challenge is to get an IV access. Sometimes it might be challenging to get an IV access. So how will you proceed? If the patient is conscious oriented, definitely you can give orally. There is no need of IV. So that is once again, if the patient is conscious and oriented, you can give oral glucose solution. What you can remember, there is something called as rule of 15. If you give 15 grams of oral glucose, the blood sugar will increase by 15 grams per deciliter over the next 15 minutes. So that's a simple rule where you can, how much sugar that you are going to give, you need to anticipate how much correction that you wanted. This is approximately how much the sugar will increase within the next 15 minutes. If the patient is conscious oriented, definitely they can take sugar solutions or whatever is available. But if the patient is unresponsive, definitely you need to have an IV. What are the other options for you? If IV, you don't get an IV access, first thing is always dextrose.
Yes.
So if you don't get an IV access, what will be the next option? You have to go an IV access and give dextrose. But getting an IV access might be challenging because of, especially in this group of patient, chronic hospital admission, maybe venous thrombosis, everything would have happened. You may not get a peripheral line. So IV access is an option, but otherwise we have an option for giving glucagon. But glucagon is never a first line agent. You have to understand, glucagon is never a first line agent, and in sulfonylurea toxicity, glucagon have no role also.
Yes.
So definitely you have to remember, glucagon can be given as an IM, 1 mg. You can give it as an IM, but definitely not as a first line agent, maybe refractory. You are not getting an IV line, maybe you are planning put an IO, maybe you can give a glucagon. But whenever you read any guidelines, it is not never any as a first line agent. It is only given as a first line agent in which situation where you suspect a beta blocker toxicity. So that is the first indication for giving glucagon. Okay. So patient coming to the EDR, our priority, we have done that. And usually 5 to 10 minutes there will be a good response.
Yes.
What will you do if the patient is not responding? In the sense, sugar level has increased, but the patient's sensorium has not improved.
Yes. In that case, we have to give it a maintenance dose.
No. Sugar level has increased. You are rechecking the blood sugar after 20 to 25 minutes. It has come to 200 or 150. So, but the sensorium has not improved.
So we must look at the precipitative factor. What caused this hypoglycemia?
See, there it's very important, the duration of hypoglycemia. So the key things, once you start correcting the hypoglycemia, the next important key thing is what? Why? How long? So outcome will depend upon how long the patient has been having this hypoglycemic episode. Majority of the times what will happen, the patient will go to bed, they will not have taken their food properly, or they will, like the same elderly lady who had some comorbidities, she hasn't taken her food properly, taken her insulin, and she has gone into bed and she had developed a hypoglycemia in between her sleep, and she has not recovered from that. So if the patient is not recovering, then the hypoglycemic brain injury can happen. So that has got a very poor outcome. So you can see a group of patients where they improve the blood sugar, but the sensorium doesn't improve to that extent, that whatever there prior to that hypoglycemic episode. So you have to consider probably a prolonged hypoglycemic episode has been happening to that patient. Then you need to, maybe after 72 to 4 days, you need to get an MRI and look for the brain damages, whatever has happened. Not an immediate. Definitely you can ask for a CT. You can look for other causes, because hypoglycemia and acute stroke, both of the things can mimic. They can just come to the ED with the same presentation. Suppose there is an underlying stroke and he can develop an hypoglycemia also. So then you have to definitely look in for the other causes. One important thing is that prolongation of hypoglycemia. How long the patient has been hypoglycemic. Now, another question that I will need to ask, any other investigation that you will be asking in this lady? Any other investigation in this patient?
It's about the infection, the blood.
Okay, what could have precipitated your inflammatory markers and all those things? What is the other investigation that you have not it's very important for this lady or whoever has come with hypoglycemia. Two important investigations that I might ask for is an renal function test and a liver function test. Liver function test may be mostly we have to look in for a PTINR. That will be idea, but LFT will be a reasonable. Why that is important? Why I am saying that is an important investigation?
So the patient's taking insulin. The insulin gets excreted through the renal route. So if the patient has already a decreased renal function, the presence of insulin inside the body is for
so the action of insulin will be prolonged.
Yeah.
Already this lady is taking a long-acting insulin, 30/70 mixed start.
Yes.
So almost 12 hours of action is there for that.
Yes.
So if she is having underlying renal dysfunction, the action will be prolonged. The next one regarding liver function, the gluconeogenesis will be affected. So gluconeogenesis affected. So that group of patient also can have frequent hypoglycemias. Then what other investigation that you want? Sepsis, you said. Sepsis definitely is a trigger because the food intake, everything will come down and they will not be having adequate food and all. So they can have frequent hypoglycemias. And age is another factor. You said dementia. So maybe the feed, everything is not adequate. And maybe OHS. If she's already taking OHS, which OHS you think is very dangerous and which is very safe?
Sulfonylureas are usually very long-acting sulfonylureas.
Examples?
Like glyburide, glimepiride.
Glimepiride is one of the bigonides.
Bigonides, metformin, they are completely safe.
Reasonably okay. What the SGLT2 inhibitors? Reasonably okay. All the other drugs, whatever we are having, sitagliptins and all, it's reasonable good drugs which don't cause. But glimepirides are very notorious to cause this hypoglycemia. And again, there is organ dysfunction. Glimepiride, you usually see the patient will be consuming it OD or BD. OD because it has got very long duration of action. So, why this information is key? These are the group of patients that we should be admitting or keeping under observation. And majority of the time, you correct the hypoglycemia, you send them home. If you are not checking this thing, they will come back. So, one on OHS, specifically glimepiride, organ dysfunction, any of the organ dysfunction, you have like CKD, you have CLD or any other sepsis like complicating, you think that the feed is going to get affected, they should be admitted. And definitely, fourth one, long-acting insulin, not short-acting insulin, long-acting insulin, it was always better to get admitted and treat the patient. Suppose you are taking another treatment for any other indication, you have to definitely admit. But generally for hypoglycemia, this will be the indications for admission. Now, since we discussed regarding normal hypoglycemic scenarios that we see very commonly, let's go back to spontaneous hypoglycemias. Spontaneous hypoglycemia, any one of us suddenly developing a hypoglycemia. Why we should not develop a hypoglycemia? That is not routinely happening. So routinely our system is so good, we have gluconeogenesis. Somewhere or other, our blood sugar is maintained above 70 milligram per deciliter. So that is our normal thing. Spontaneously, none of us, even if we are fasting 24 to 40 hours, we should not develop a hypoglycemia. If you are developing a hypoglycemia, what could be the reason behind it?
Yes. Due to a pancreatic dysfunction.
So you have to look in for the next important differential diagnosis. Spontaneous hypoglycemia you have to consider is what? Insulinomas. So insulinomas, when you have a suspicion, that is the time somebody is coming, a young man is coming to the ED. Last time he had come on your shift and you have treated him and you have sent him home. And again he has come back with a hypoglycemia. You have seen him again. That is the time that when you're putting an IV line, get the samples for 3 investigations. 1,
serum insulin
level, C-peptide level, and serum cortisol level. So these are the 3 major investigations that you will collect. Blood sugar definitely we will do. That's agreed because you have to do and look for hypoglycemia. So 3 investigations you have to ideally do at the time of hypoglycemia. And another group of patients, since we are dealing with emergency, you have got a patient, young chap. I'll give you a scenario. He's like not a young chap, maybe a 70-year-old male. Okay. He don't have any other basic comorbidities and he has come with hypoglycemia to you. So, I am telling you it is a medical legal case. That's a clue that I am going to give you. Self-injection or somebody has tried to kill him. So, how will you differentiate by doing our investigations? Insulin level will be very high, but C-peptide level and other will be normal. So, you can have insulinoma producing insulin. So, C-peptide and insulin will be high, but when somebody is inadvertently injecting self or somebody is trying to kill him, it will, serum insulin level will definitely go up. Why? Because insulin we have injected, but C-peptide and all will not go up. So that is a differentiating features that you have to keep that in your mind. Very important, because we deal with medical legal. One elderly patient is frequently coming to the emergency room, being taken by a caretaker. So we have to have all these suspicions in our mind. Without any reason, he is developing hypoglycemia. Is it what is happening? And another common mistake that patients will do, what is the insulin syringe that they are using? There are different types of insulin syringe, and the dosing. There are 100 IU per ml is there. There is some 200 IU per ml is there. There are different dosing available. Suppose the pharmacist has given them and different dosage. Suppose initially it was like 100 IU per ml. Instead of that, he has given something like more preparation, so the patient can inadvertently increase. So, or the size of the insulin syringe. Previously, there are different types of insulins commonly available in this. Okay, some of their relatives would have come from abroad and they have given them some insulin syringes. That's like that. We had a patient. Then that why I am telling you this education. Whenever you are getting hypoglycemia, you need to go behind why he is developing this hypoglycemia. So when we tried out, then we found out that he has been using a new insulin syringe, which will take more amount of insulin. So that was the reason for his hypoglycemia. So educating the patient, even when you're discharging from the ER, you have to think that it is due to insulin or due to glimepiride. That is fine, but you have to definitely see and teach them what is hypoglycemia, what are the symptoms of hypoglycemia, when they should be alerted, what they should do if they are getting frequent hypoglycemia. Specifically, when the patient is getting discharged from the hospital, what will happen is that they will not be taking adequate feeds. But once they go home, they will start eating well and they will develop hyperglycemia. So whenever they see hyperglycemia, they will start increasing the insulin dose. They can go for hypoglycemia. So you should teach them what are the symptoms, what they should do. But there will be a group of patients who like 3 a.m. the blood sugar will suddenly become low. So that is a very common. We wanted to get it under very good tight control. So when you look at the HbA1c targets, when you have a young adult male, you wanted to less than 70, maybe a little bit elderly with a little bit of comorbidities, maybe less than 7.5. Maybe with significant comorbidity, we are not targeting any of the HbA1c control. Like for this lady, I will not have any of the HbA1c target for her because she is already 81. She is having frequent hospital admissions. Dementia is there. Aspiration pneumonia is there. So I don't keep any HbA1c target for her. What will be my priority is to prevent hypoglycemias in this lady. Okay. So similarly, they can go home. What advice that you can give when young patient, if they are developing like 3 a.m. hypoglycemias and all, what you should be telling them? What usually they will take insulin around 8 o'clock and they will have their food and they will go to bed by 10:30. That's a usual routine for many of them, and many of them have different place. Maybe at around 10:30 or something, they can have a small snack before going to the bed. What type of snack you will prefer? Which has have a
high carbohydrate,
glycemic index. That is more important. Which should have a high or low glycemic index. Low glycemic index. So you wanted to give a low glycemic. What is the sudden surge of sugar? I don't want. I want a food item that will be slowly absorbed and it will be there in the blood for some time. It should be slowly absorbed. So something like a low glycemic index food will be preferable. When you have a carbohydrate, like we are having a good meal in the afternoon, suddenly there will be surge. When you are having rice, there will be sudden surge. But when you eating wheat, that surge might be little bit, but there is a surge, but it will not be like peaking of what is thing. So that is the reason why majority, can I take chapati? The patient will come and ask. The only thing is it will take time for digestion little bit more, so the patient will not feel hungry. And another important thing is that what diet advice that you wanted to give. Definitely they will ask, doctor, what diet I should take? I am completely avoiding carbohydrates. I am not taking any of the sugar, but still my sugar is not getting control, or I am getting hypoglycemia. This will be the two issues that they will comment on. So we wanted sugar control. The only advice that you need to give them is the diet advice is what? Sugar definitely they need to avoid. Instead of having 3 meals a day, they need to divide at 5 to 6 smaller meals. So they will not have this hypoglycemia or hyper peaking of sugars won't happen. So this is the simple things that you can all teach. Education is very important. Hypoglycemia as well as hyperglycemia education, very key in this group of patients. Okay. So what is Whipple's triad?
So Whipple's triad is the question of hypoglycemia. Then after giving glucose, the hypoglycemia improves, and the symptoms of hypoglycemia and improvement of hypoglycemia after giving sugar. Simple.
Yes. the Whipple's triad for this thing is very simple thing. That is a diagnostic index. So how will you classify different levels of hypoglycemia? What is level 1, level 2 and severe hypoglycemia? Level 1, it is not very useful, but when you say hypoglycemia, level 1 hypoglycemia, there is one guidelines which says that level of blood sugar less than 70, you can, or 3.9 millimoles per liter, you can call it as level 1. Level 2 less than 5, that 54 or 3 millimoles. And severe hypoglycemia, that is unconscious patient that is coming, you can call it as severe hypoglycemia. Level 1, level 2 and level 3. 3.9, 3. How will you convert millimoles into milligram per deciliter? You are all going to write UK exams, which are into 18. Into 18. So that is the reason why we are having our formula. Which formula? Which formula that we are using divided by 18?
Serum
osmolarity. Which one? Blood sugar divided by 18. We are converting into millimoles. That is the only reason. That is the only reason we are having 18. If you know it is millimoles, no need to divide by 18. So when you are converting this, that's the conversion factor for blood sugar, because it's very difficult for us to remember 3.9 and 70, 3 and 54. So into 18 is the formula that you can remember. Okay, so this patient was admitted or discharged?
So the patient was admitted.
Okay, so definitely she should be admitted because there is sepsis, age factor, feed, dementia, all those factors, she should be admitted and evaluated. Anything else that you have to add? So what will be the take-home message in hypoglycemia?
So we just constant GRBS monitoring and
correct the sugar first.
Yes.
Whatever is the available solution, correct the blood sugar.
Yes.
That is the only thing. Don't think about anything else. Whatever be the reason, we will evaluate later. Correct the blood sugar first thing. Pediatric, whatever be the age group, you correct the blood sugar first, then you evaluate the patient, and whom to admit we have discussed. Okay?
Yes.
Fine. Thank you.